I'm Dr. Foss, current family medicine resident and developer of MatchPal's OMM Bootcamp. I've spent hundreds of hours teaching students how to succeed on COMLEX, and today you'll get to see a short preview from our OMM Bootcamp review course where we cover every single high-yield OMM topic on COMLEX Level 1 and 2 and break them down into digestible, short, focused videos. If you're interested in getting instant access, check out the link in the description. Enjoy! In this video, we'll discuss the principles of cranial OMT. Osteopathy in the cranial field was first established by Dr. William Garner Sutherland. Dr. Sutherland studied and described the primary respiratory mechanism, or a subtle rhythmic motion palpable through the body at all times. It's important to note that the primary respiratory mechanism, or the PRM, is completely independent of the respiratory movement that happens when we breathe in and we breathe out. The PRM relates to the central nervous system, brain and spinal cord, cerebrospinal fluid, dural membranes, cranial bones, and sacrum. In order to understand the PRM, we're going to define the reciprocal tension membrane, or the RTM. The RTM is an inelastic rope-like structure which includes the falx cerebri and the tentorium cerebelli. The reciprocal tension membrane relates to the dural folds that we discussed in lesson 1. As discussed, the dura and also the RTM ultimately attaches to the sacrum and is characterized by continuous dynamic tension. So what does dynamic tension mean? The RTM becomes taut in some areas with cycling motion while slackening in other areas. And that's how this dynamic tension balances from one area of the RTM to another. The reciprocal tension membrane operates from a fulcrum, and this fulcrum is found along the straight sinus, also discussed in lesson 1. In other words, the dural folds sickle in some areas, becoming taut, while slackening in other areas in order to balance each other. And that comprises the dynamic tension of the reciprocal tension membrane. With all of this in mind, let's discuss the different elements of the primary respiratory mechanism as described by Dr. Sutherland. Dr. Sutherland believed that the PRM has 5 anatomical physiological elements, or 5 phenomena of the PRM. These 5 phenomena are extremely important to know for COMLEX. COMLEX question writers love asking questions on those. The 5 phenomena are the inherent motility of the brain and spinal cord, the fluctuation of the cerebrospinal fluid, mobility of the dural membranes, mobility of the cranial bones, and involuntary mobility of the sacrum between the ilia. We're going to go over each one of these phenomena. It's important to note the difference between the word motility and mobility. Motility describes the inherent ability to move spontaneously or independently on its own, while mobility refers to a structure being moved by an external force. With all that in mind, let's go through each of the 5 elements of the PRM. Inherent motility of the brain and spinal cord. This component describes the subtle motion of the central nervous system as it coils and uncoils. Once again, it's important to note that this motion is independent of respiration and cardiovascular pulse. The fluctuation of the cerebrospinal fluid and the potency of the tide is something that Dr. Sutherland described as an integral component of the PRM. Fluctuation of the cerebrospinal fluid, or the fluid that surrounds the brain and spinal cord, also undergoes rhythmic pressure and volume changes. Those changes influence the tissues within the body. Now, the mobility of dural membranes. Dural membranes, arachnoid matter, and pia matter, or the meninges, which all support the central nervous system, are related to the reciprocal tension membrane. All these structures are being moved as a result of the inherent motility of the CNS and the fluctuation of the cerebrospinal fluid. Next, we have the mobility of cranial bones. This phenomenon describes the articular mobility of the cranial bones relating to the subtle movement at cranial sutures. In cranial OMM, sutures are believed to retain some degree of flexibility even in adulthood when they've already fused. Involuntary mobility of the sacrum between the ilia. This element describes the transmission of cranial motion to the sacrum
via the dural connection. The sacrum, as a result, exhibits involuntary rocking motion synchronous with the cranial rhythm. To put it all together, meninges act as an inelastic rope causing mobility of the cranial bones in response to the inherent rhythmic motion of the central nervous system comprised by the brain and spinal cord, as well as the fluctuation of the cerebrospinal fluid. The reciprocal tension membrane connects the cranium and the sacrum, attaching to the superior aspect of the second sacral segment and causing the sacrum to move with reciprocal tension membrane motion. When it comes to cranial OMT, the cranium will be divided into a cranial base and cranial vault. The cranial base consists of the occiput, sphenoid, temporal bones, and ethmoid, while the cranial vault is made up of the two parietal bones and the frontal bone, which, if you recall, contains two parts. The motion of the cranial vault bones, parietal and frontal bone, will be used to assess for cranial dysfunction, and that will be done through the vault hold. We'll discuss the vault hold and the specific contact points in Lesson 4. Another important component of cranial OMT and cranial motion is the sphenobasilar synchondrosis, or the motion of the SBS. The SBS is at the center of the cranial base. Therefore, the SBS is an excellent reference point for cranial motion and oftentimes used in nomenclature when it comes to cranial diagnosis. So, how do all the cranial bones move? When it comes to cranial OMT, we'll divide cranial bones into midline versus paired bones. Midline bones will primarily move into flexion and extension. Those would be the sphenoid, occiput, ethmoid, and vomer. The paired bones will be the frontal, temporal, and parietal bones. Remember, the frontal bone is considered a paired bone, as the two components are separated by the metopic suture, as discussed in Lesson 1. Paired bones will move into internal and external rotation. Two sutures to note when it comes to cranial motion are the serrate and squamous sutures. The serrate suture, which is the sagittal suture, consists of interlocking spicules. That suture exhibits rocking motion. In contrast, the squamous suture consists of overlapping and little interdigitation. The squamous suture will exhibit gliding motion. Think back to the principles of OMT in general. Structure and function are closely related, meaning interlocking spicules associated with rocking motion, while overlapping associated with gliding motion. Now back to the PRM as described by Dr. Sutherland. The PRM comprises the physiologic cranial motion into flexion and extension. This motion entails rotation of the midline bones during PRM inhalation and exhalation respectively. Remember, PRM inhalation and exhalation are independent of respiration through inhaling and exhaling air into your lungs. Cranial flexion, which is part of the PRM inhalation phase, will entail the SBS moving superiorly and associated with transverse widening or swelling of the cranium. Cranial extension, which is part of the PRM exhalation phase, will include SBS moving inferiorly with associated transverse narrowing or receding of the cranium. The CRI, or cranial rhythmic impulse, is the palpated rhythmic motion of the cranium, which is a manifestation of the primary respiratory mechanism, or PRM. So CRI is a proxy for measuring and quantifying the PRM. A normal range for the CRI is 6 to 12 cycles per minute. Some texts may cite up to 8 to 14 cycles per minute. The CRI can be decreased or increased if abnormal. A decreased CRI may be associated with depression, physical or psychological trauma. In contrast, an increased CRI may be associated with bipolar disorder. This table summarizes the differences between the two PRM phases, inhalation versus exhalation. This table is high yield for COMLEX. Question writers love asking questions on the different phases of the PRM, and what type of movement of what component is associated with each phase. Let's go over inhalation and exhalation phases of the PRM. In inhalation, the midline bones go into flexion. The pair bones will go into external rotation. A way to remember this is the two EXs, flexion, external rotation. In contrast, in inhalation, we have midline bone extension and pair bone internal rotation. And it is exactly this extension and internal rotation that will result in the receding of the cranium during the exhalation phase of the PRM. The SPS during inhalation will become more superior and become more inferior during exhalation. The CNS during inhalation will shorten and widen as it's coiling, and during exhalation, the CNS will lengthen and narrow as it's uncoiling. During PRM inhalation, the sacral base will become more posterior superior or going to counter nutation along that superior transverse axis of the sacrum. And during exhalation, the sacral base will become more anterior inferior or nutate, nodding forward. The falx cerebri. During inhalation, anterior posterior diameter will decrease, while during exhalation, the anterior posterior diameter will increase. Finally, the tentorium cerebelli will exhibit transverse flattening during inhalation of the PRM and transverse stenting during exhalation. Remember that the cranial base will generally move in flexion and extension, while the cranial vault, including the paired bones, will generally move into internal and external rotation. These two images help visualize the two phases of the PRM, inhalation on the left-hand side and exhalation on the right-hand side. Here you can see the cranium, and the dotted line is showing how the cranium is changing through each of the two phases. As we said, with PRM inhalation, the sphenoid and the occiput will go into flexion. The sphenobasilar synchondrosis would move superiorly. The sphenobasilar synchondrosis is right here, and the CNS will shorten and widen, demonstrated by these arrows here. The sacral base will move into sacral counter nutation or posterior superior as the AP diameter of the cranium decreases and the cranium swells up. The tentorium cerebelli would exhibit transverse flattening as it's pulled to the side. The transverse diameter will also widen. Now, PRM exhalation phase. Once again, here we have the sphenoid and here we have the occiput. The sphenoid and occiput will move into extension. The SBS will move inferiorly as the CNS is lengthening and narrowing or uncoiling. The sacral base will move anterior, inferior, or nodding forward into nutation. These changes will result in increase of the AP diameter of the cranium, as well as transverse stenting of the tentorium cerebelli, or decrease in the transverse diameter. And this is all you need to know about the principles of cranial OMT in order to do well on COMLEX.